Here. This is a great honor, and this is a topic that's very near and dear to my heart because I'm an epileptologist by training, but behavior and neurology is such an important thing to patients and to physicians, and I'm glad that I have the chance to just stand here and talk about it. I will focus today on talking about the cognition and behavior in our patients with PCDH19 because seizures are bad, seizures are terrifying, but they're only part of the story.
I don't think I started your slideshow.
That's okay, I'll put it in slideshow mode. So what I'll be talking about, first of all, is what we know so far, and that will be a review of the literature. What we can learn from the registry and what we have learned so far in terms of development, in terms of autism spectrum disorder, behavior, mood disturbances. I'm going to talk very briefly about epilepsy and behavior connections, and then what are our future directions. To begin, however, I wanted to hear from you. I only have 5 slots here, so I have room for 5 wishes, but it's going to be very quick.
Raise your hand.
Couple word wishes that
Stop the impulsiveness.
Okay.
Stop impulsivity.
Sleep.
Sleep.
Sleep. What's that? Amanda.
Say it again.
Amanda.
Oh, right. Yes.
Aggressiveness or aggression, like violence.
Violence. Okay, so aggressive behavior. Okay. OCD.
No
More.
more seizures.
Had your chance.
Okay. My disclosure is that I don't own a lamp and I have no relationships with the genies, but I'm going to talk as much as I can about what we have learned so far so that we can move forward. Just so that we're all talking about the same things, I have this slightly busy slide. So when we say idea, we're going to be talking about intellectual disability. DD will be developmental delay, and GDD will be global developmental delay, meaning delay in 2 or more areas of development. ASD, as you know, is autism spectrum disorder, OCD for obsessive compulsion, ADHD for attention deficit and hyperactivity, and I tend to refer to mutations as variants. So if I use the word variant, I am referring to the same thing. It's just more of a new nomenclature thing. Just before we are absolutely sure about something, we are tending to call it variant. So if I say that, I'll be talking about the same thing. And then I also would like to go over the new definition of autism spectrum disorder. This just came out with the new DSM-5 about maybe a couple of years ago. Because nowadays there is only autism spectrum disorder and everything falls under its umbrella. We are no longer calling syndrome as pervasive developmental disorder or infantile autism or autism on its own, or even Asperger's. So basically everything is being lumped under the same umbrella, and the criteria for diagnosis are rather strict. And basically there has to be deficits in those 2 main areas, which are social communication interaction, and there has to be restricted and repetitive patterns of behavior. In addition to that, the symptoms have to have happened early, cause impairment in function. They also cannot be better explained by intellectual disability or global developmental delay, which sometimes can be the tricky part because a lot of children who suffer from intellectual disability might look like they have some autistic features, but might not necessarily have autism. And I also would like to draw the differentiation between autism per se, or full diagnosis, and autistic features. Until a few years ago, there have been a few case reports. It's a pretty new gene, and as soon as the gene was discovered, the cases and the case series started trickling in, and there have been reports of obsession, aggression, self-injurious behaviors, hyperactivity, impulsivity, and autistic features. It wasn't until 2012, the group Camacho et al. Actually reviewed every single patient that had been found in the literature, and there was one male. I think we keep forgetting to talk about him. He was reported in the first paper by Depian. They did have one male in their cohort in 2008. So they found that a vast majority of the children, 75%, had intellectual disability. More than half had behavioral problems, and nearly half had autism spectrum disorder. So numbers here are quite striking. And then here what I did is I went through all of these studies again just to go over the numbers and basically tried to calculate everything again just based on the individual studies. And as you can tell, there is a little bit of variability, and basically the intellectual disability in those studies varied anywhere from 50% to 100%. But that could also be what Dr. Gibbs was talking about, the bias of reporting the patients who are either more affected or have something that's a little bit more unusual. In terms of psychiatric symptoms, that included autism spectrum disorder as well. There's a debate whether we should put it in this category or not, but just for the sake of reporting here, it ranged between 30% to 100% of patients. Again, a pretty wide range, but overall, intellectual disability, as I just said, was 75%, and the behavioral symptoms were a little over a half. And then even more recently, there was this very nice study by Dr. Specchio's group that basically went over the cognitive development in the females. They took 11 females. They did the standardized assessments that we have been talking about earlier. And the cognitive assessments were done depending on age. When formal evaluation was not possible, they sent out Vineland adaptive behavior scales to be done so that the parents could do them. At the time, the DSM-5 was not available yet, so the ASD symptoms were diagnosed according to DSM-4, and the psychiatric diagnoses were all given by neurologists or neuropsychologists. And the summary of the finding, interestingly, it was very nice because they did a follow-up after 1 year, which is very helpful. There were no major changes from the baseline and the follow-up 1 year later, but that was a very good experience and a very good example of getting further information 1 year down the line. They found that there was cognitive development impairment in 6, so again, nearly half. 2 were mild, 3 were moderate, and only 1 was severe. Autism spectrum disorder was found in 5 out of 11. And then behavioral issues were again found in a little bit over half. Again, the main features were hyperactivity or inattention plus hyperactivity or just inattention, as well as aggressive behavior. The most recent study that just came out a few weeks ago from France by Rima Nabout's group and the Delphine Bruyère. So they basically focused on the autism spectrum disorder itself and the intellectual ability in the girls, and that included 8 patients. It was very nicely done because they did go by questionnaires, adaptive questionnaires that the parents had to fill, but also from standardized cognitive assessments. So they had both of these data points to go with, and from those results, 6 out of 8 patients, so nearly all, had significant behavioral problems, and they reported attention being the main problem. And then the results from the cognitive assessments were pretty similar to what we have found so far in the literature. 2 had mild delay, 3 had moderate delay, 2 had no delay, and 1 had severe intellectual disability. Autism spectrum disorder was formally diagnosed in 6 out of those 8 patients, with the caveat that, what I mentioned in one of my earlier slides, autism spectrum disorder sometimes can be extremely difficult to diagnose in patients with severe intellectual disability. I went through to figure out if the young men were at all different from the women, and we have 4 young men that have been reported in the literature so far, and their picture is overall similar. I know the number is very small, so I cannot really draw real conclusions, but behavioral dysregulation, Intellectual disability, again, OCD and ADHD seem to be the common theme. Looking at all of this data and what we have so far in the literature, what we wish we knew more about. So first of all, there's very scarce data on the therapies that are specific for the behavior and other behavioral therapy methods that could happen at school or at home or any specific behavioral programs. The behavioral phenotype itself is not very well defined. We do read a lot about the specific types of behavior, but how many girls, how many boys have this specific behavior? What does this behavior do to them? At what age does it start? Is it worse with the anti-seizure medications, or is it better? What is the effect of seizures on this behavior? Do the seizures make it better? Do the seizures make it worse? And then how is this affecting the quality of life? Because on top of the seizures, we are dealing with on a daily basis with even more behavioral dysregulation. So to go back to our registry, which Lacey and Nilika very nicely presented, they I think did my job for me because they went through what we have. So based on the registry alone, this is the data that has been extracted. And I'm going to tell you right off the bat, this data is not enough to make definite conclusions. This is pretty observational, pretty preliminary at this point. But it's important for us to know how much information we can extract from this database, and then what more do we need and where do we go from here to gather more information in more detail. So our questionnaire, as many of you know, did include a few questions on autism spectrum disorder and behavior. It did include that free paragraph where we were able to actually learn more specifically and more personally about each one of your children. There was some neuropsychological evaluation apparent. We were very happy when we were able to get this data from the records because that gave us more objective data. We also gathered some data from neurology notes, and there were some, I would say probably more than some, there was quite a few psychiatry notes which told us the impact of this disorder and how many of these girls actually ended up seeing psychiatrists. In terms of the developmental phenotype, and I have to note, my numbers might be a little bit different from the numbers that Nilika and Lacey reported. I'm only reporting our cohort from Boston Children's, what we have from Boston Children's part of the registry. But I also did a slightly more in-depth and look at every potential detail I could gather in the chart to figure out what we have. So I have 17, so 16 out of 17 here is because I don't have enough data to make a conclusion on the remaining girls. But for the 17 girls that I had data on, 16 were completely normal before their seizure onset. There was regression in at least 10, and all of the regression happened around the seizure onset. There has been nobody reported to have had regression outside of a seizure cluster, outside of their, and it could have been the first seizure. In a very few cases it was maybe the second or the third cluster, but most likely it was during the first cluster of seizures. And this also includes the patients who even got better after the regression, so I'm just going to have to put this disclaimer, but it was still a regression because even if they got back to their baseline, that might have taken them effort and they might have lost some time in order to get back to their baseline. And then I looked into what those girls look like now, or at the last time they were evaluated, and at least 6 had motor delay, 11 had speech delay, and 6 had social delay. I think this correlates more with what Dr. Specchi was talking about later, that speech was actually one of the areas that was much more affected. It's interesting too, we do notice that the social area, while affected, is not as extensively affected as the speech is, even though we are finding more and more autism spectrum disorders. So this would be very important to tease out. And then at least 10, or about 60%, had either global developmental delay or intellectual disability, depending on the age that the final data was done. And then when we looked at autism spectrum disorder, this formal diagnosis, I only included the ones where either the neurologist or a psychiatrist or there was a neuropsychology evaluation or an ADOS that was done, and about a third actually did fit the criteria for autism spectrum disorder. Additionally, at least 4 other patients had autistic features. In terms of neuropsychiatric symptoms, and that typically includes psychiatric symptoms, but also other symptoms that can be caused by rather neurological conditions, I looked into mood problems. It wasn't something that we asked very specifically about. The majority did answer that our girl is very happy, except for when she has the behavioral outbursts. But I did find in at least a quarter of these girls, there was a report of issues with mood lability or concerns for mood problem, which is, I think a quarter is quite a big number, especially at this age, to have mood difficulties. Behavioral issues was about 64%, so a little bit more than what we saw overall in the literature. And I'm just gonna give you the list, which you all know and are familiar with what has been reported, including meltdowns and agitation and tantrums and the OCD-like behavior, anger issues, impulsivity. Looking into ADHD or formal ADHD diagnosis, so that excludes when we say inattention or hyperactivity. It's just formal diagnosis, again around a third. And aggression, as many of you have mentioned, is present in at least a quarter of these girls. So again, this is the numbers remain quite striking. Because there was really no data known about medication, I looked through what are the medications that have been used, just specifically for behavior in these girls. And pretty much all categories have been used, from antipsychotics to even anti-epileptics that have been used more for behavior than for seizures, such as Lamictal and Depakote. Stimulants, non-stimulants, again, medications to treat depression, mood, anxiety. And many of these I'm not a psychiatrist, but I can tell many of these medications do overlap between categories. So sometimes you might use one to treat a certain symptom that might belong to another disorder, and that's okay. Unfortunately, the effects are not well vetted yet. So I know that one of the questions is which medication works best, and unfortunately, we don't know yet, and that's one thing that we should definitely focus on in the future. In terms of how the seizures affect the behaviors and vice versa, I did not find a very clear pattern. So I know Dr. Specchio yesterday had talked about early onset seizure was somehow correlated with worse development and behavior in the future. I haven't necessarily found that, but then again, our cohort is smaller. And basically, we couldn't pinpoint a clear overall chronological pattern, but that could also be because we don't have the full data. We don't have the day-to-day data of when does the seizure happen and how bad was the behavior before the seizure happened. Many have reported, and I've heard this from many of you, that the behavioral issues are worse before the seizures happen. But there are also reports of worsening behavioral problems after the seizures for a couple of days. So it might be a two-way street here. In terms of anti-seizure medications, there are a couple of culprits that we know about from the literature. We know about from our experience with patients in general from the epilepsy realm, that Keppra has been associated with a lot of behavioral problems with many of the girls. Clonazepam, clobazam, other benzodiazepines as well. Rufinamide in a small subset of the girls. But my disclaimer here is that they can be well tolerated and effective in certain girls, but not in others. So it is very difficult to tell from the get-go. And I do not mean this slide to discourage anyone from trying a medication. I'm just basically telling you what we have noticed and what we have seen so far. And then the mood stabilizers that have been used were lamotrigine and valproic acid, and it seems they were rather well tolerated. So how can we help from a clinical research standpoint? First of all, we are really hoping to refine the behavioral phenotype, and then going from that, better understand the effect of the anti-seizure medications on the behavior, and then also understand the response to psychotropic medications, and if there are better medications to use in this area here. The limitations, however, we have talked about the limitations during our prior conversation. There are many variables involved here, so we need a very large number of participants because we have to correct for a lot of the variables. And those variables can include the time of seizure onset, the age of seizure onset, other behavioral problems, the intellectual disability, the autism spectrum disorder, the medications that are on board, the sleep. So there are many, many other things than just the behavior alone. So standardized tests are definitely the gold standard, and this is definitely something that we have to do. They are, however, reflective of only a single time point in, not necessarily in the child's life, but in the child's year or 6 months, or depending. So we might catch them on a good day, we might catch them on a bad day, and that might not be representative of how well or how bad they're doing on any other day of the year. And that's where we go to subjective reports, and these can be extremely helpful for us. And as you were just saying, there are things that we wouldn't know to ask you because we wouldn't really have the level of detail that you know about your child. However, the problem here is going to be that a meaningful comparison is not going to be possible, because what is severe for someone might not be as severe for somebody else, and vice versa. So this is where we are having some of the pitfalls, and what we're hoping to get to is a combination of both objective, quantifiable data, as well as some qualitative reports that we can use. But we definitely need both. And the most difficult thing here is that no two girls are alike. It's been so, just looking through every single child's history, meeting every single child, they are so different, and that's a wonderful thing because each one of us is special, but at the same time that might make our job a little bit more difficult. We hope to find something and says, well, this medication probably works very well for the majority of these girls, but don't be discouraged if it doesn't work for your girl, because there might be something different, and there are a lot of other factors. So we continue to strive, we continue to look forward to finding the right combination. And my personal policy, and it might be different from other epileptologists, is that I don't necessarily give up from the first couple of anti-seizure medications, because there might be a magic combination that works at some point, and I would hope that for behavior that might be the same, but that doesn't come without a cost because of the side effects and the time and all of the trouble associated with that. So for now, our future directions, Lacey has already gone through, first of all, just the direct collaboration between the registries. But what we also want, so the goal of the registry would be to try and capture the general idea, just go over, what do we deal with the most, what do we want to focus on in this disorder. But the goal of the registry would not necessarily be to get the fine details about how every child behaves, how every seizure looks like, how every EEG looks like. And that's why we're going to need even more thorough clinical evaluation. And we have been having a lot of discussions in terms of how would be the best way to do that, and we're hoping to find a solution to that soon through having kind of a second level of the data collection and vetting and clinical evaluations whenever it's possible, to do more standardized testing and get more observation and parental reports from you. And I think one thing I didn't put in this slide, but that is very important, that I had been planning to do all along, is to try and also get school reports, because it is so important to see how these girls are behaving at school, and it will be even more important to know what kind of behavioral interventions would help them both at school and at work. And our common goal, as you all know, is really to find therapy for both the epilepsy and the behavioral challenges. In the clinic, the way we can help, and I'm using this as a segue to the next speaker. I'm very excited to hear her talk. We really need a multidisciplinary approach, because epileptologists and neurologists sometimes are busy. They have 30 minutes to figure out how to deal with the anti-seizure medications and figure out the seizures and show safety and all of that. But then what about the behavior? So what would be really ideal is to have a clinic that includes a neurologist, but on the other side also includes someone who is specialized in either psychiatry or psychology or even behavioral pediatrics or behavioral neurology, to help with that aspect and work together with the epileptologists to better understand the interaction between the medication and the psychotropic medication. Some people are nervous about starting certain psychotropic medications because they worry they might cause seizures. And the other way around, we are sometimes worried about starting certain anti-seizure medications because we are worried about them causing more behavioral issues. And then we will have more ability to offer appropriate behavioral support both at home and at school, and to better understand the day-to-day struggle with the behavior and seizure. And with that, I will end. I would really like to thank you all. I mostly thank our patients and their families. And this is just a sample of our lab, but I highlighted the people who are working very closely with this project. And I also want to thank Dr. Sarah Spence and Katrina Boyer, who are not with us today, but Dr. Sarah Spence is a world-renowned autism specialist who has been very interested in helping us tease out this topic, and Dr. Katrina Boyer is a neuropsychologist who has also been working with us on devising the best testing methods for these girls.
Any questions?
So yesterday we learned that the seizures can stimulate the amygdala and cause the fear response. Are there medications that can specifically trigger that part of the brain that might be helpful for their behavior, if that's a big part of it?
That's a very good question. So to start with that, it's not sure whether the location where the seizure starts is the same thing that's causing the behavioral problem, but it is a very valid point. We know from other examples, like from temporal lobe epilepsies, we tend to see more, for example, memory problems. So there might be an anatomical substrate. I'm not aware of any medication that works very specifically on different areas of the brain. But out of the medications that we have talked about, we can definitely think about, for example, antidepressant medications or things like that that can work. And I think because I'm not a psychiatrist, I'm not going to venture more into talking about very focal. We know from the epilepsy experience that some medications work better on focal seizures, meaning starting from one part of the brain, and some work better on seizures starting from all over the brain. But from the psychiatric standpoint, I'm not going to venture into telling you like a specific category, but definitely something to look into. It's a very good idea.
Any other questions? Yeah.
For the registry specific,
Yes.
what roadblocks are you having and challenges are you having in order to gather more data? And you have an army of families in the
Wonderful
Alliance that
question.
can go out and attack that, whether you're having resistance to people filling it out or whatever we can do. Tell us what we can do to assist in gathering more data.
So for the registry itself, I think you guys are doing a wonderful job, and both Nilika and Lacey can attest to that. The questionnaire that is being filled is extremely helpful to try and capture the general idea. But in order to get the smaller, like the very fine details, that goes a little bit beyond the registry, and that would basically be our role as physicians. And what we do is recontact the patients and see if they are interested in us seeing them, evaluating them further, doing more questionnaires, whether over the phone or by writing, and then obtaining the medical records. So these and that's why I wanted to distinguish between what Lacey is doing in terms of her work with the registry and what we're trying to do here, which is using the registry as a way to find who are these girls and what are the questions that we want to ask ourselves and ask them. How can we better help figure out these questions? So yeah, thank you. You guys have been doing a great job, but the next step is probably going to be on us.
So I have a question regarding, you presented the data from Boston. Do you not have are we merging the two?
We are, yes. We are planning to merge
That was
them,
my question,
definitely.
because the UCSF one wasn't set up when we enrolled, so we're enrolled in Boston, but we would like to help out however we can. If we can travel to see somebody to be evaluated, but we're not going to go to Boston, we would come here. Is that okay?
That's absolutely fine. So based on this data, we haven't done any direct evaluations yet. We are planning to, and we have a team that's going to do that. But we are definitely planning to merge all of the data that we acquire. Absolutely.
I just wanted to make sure that we could be registered in Boston, but still, if we're going to see someone to be evaluated, we could come here instead of fly to Boston.
Absolutely.
Okay.
Anyone else? You have one more?
So what would it take to, as layering onto that question, to even grow the registry to be more global and be more, I know it's only really happening right now in these two regions, but how is it possible to continue and further that into a more global registry? And I know that data, you're looking also for the clinical data as well, which that's a whole nother process, and possibly the registry data specifically is not all you need, but
Correct.
having more of that and having data is data, so the more you have of any data that we can look at, right?
Absolutely,
the more
we
answers
do
can
need
get.
more numbers. There are so many variables. We can't really make a conclusion just based on these numbers. But to further grow the data, to further grow the registries, I think first of all working with the international groups, which we are hoping to do. So put all of our efforts and our data together. And I think Marina was talking about that earlier, about maybe involving more physicians in the United States. And while we don't necessarily need to open different registries, we might be able to kind of tap more into clinics rather than just patients and ask, do you have any children in your clinic who have this variant or this mutation? And that might actually help us get even more patients in the United States specifically. But for the international cohorts, we are going to basically rely on collaboration with our colleagues from different countries.
And just to echo on that, each site, the UCSF site and the Boston Children's site, has enrolled kids from all over. So not all of the data presented are from kids who are followed at either center, but people from the Midwest and from Australia and Europe and other places. So on the Alliance website are links to contact either group, and that would be the place to start in terms of getting the word out, and so people from all over the world can register at either site, at either center.
Have you put an article or a news kind of thing in the Child Neurology Society meeting stuff?
That would be the best way to go by. I was just thinking about that actually. We
They
can
also-
capture a lot of the residents, fellows, child neurologists, so that would be a very good place to start.
Yeah, because they push emails all the time.
They
You
do,
get
I know.
those?
I get those
You
all
just
the
have to pay a little fee, and they'll do it for you too.
True.
Just to follow up on reaching out to physicians, I wonder, when our daughter was diagnosed, the only way we found the Alliance was by Googling, and it was thankfully the first thing that came up. But I'm just surprised that our physician, who's fabulous, didn't have the resources to say, or maybe the geneticist or somebody say, okay, here's where you can go to get more information. You should register your child, that kind of thing.
Absolutely. I think I was actually just thinking about that before you asked this question, trying to capture it through the majority of the physicians in the United States are members of the Child Neurology Society, so that might be a very good way to try and capture.
Geneticist as well,
And
like when you
geneticists,
get
yeah, we can.
your initial
I'll leave
diagnosis.
that up to Lacey. Basically, she'll know better about the genetics networks, but definitely from neurology, we can definitely do our part.
Great. Thanks, Christelle.